Good afternoon. Welcome back from lunch. First of all, let me introduce myself. I'm Gabriel Leung from the University of Hong Kong. I'm standing here in trepidation because I'm a doctor for my sins, and in a room full of economists, I think that I'm about to be sort of gobbled up and chewed over. So I shall make sure that I don't speak too much. My job is really a traffic cop here, but it's a huge pleasure to be amongst you guys this afternoon. And first of all, thank you to the World Bank and to UST for co-hosting this seminar. And thank you to my friends here for asking me to come out to spend an afternoon in this lovely new facility of the University of Science and Technology. Without further ado, please may I now introduce Aparnaa, who, of course, all of you know because she has helped put this whole program together and was mainly responsible for having me out here. She's now going to introduce, by way of 15-20 minute presentation, this afternoon session, which is about, of course, long-term care and how we try to think about and frame the issues from a regional perspective. So, Aparnaa, please.
Thank you, Gabriel. So as Gabriel mentioned, this is essentially an overview to give you some sort of background to the health and long-term care situation in the East Asia Pacific region. So as we've already heard a little bit about this morning. The East Asia Pacific region made significant investments in child health over the past few decades. And the consequence of that was a huge increase in survival chances to adulthood. So between about 1970 to 2010, there were mortality rates in every age group declined, and the declines were faster for women than it was for men. And the consequence of that is this rapid increase in aging, which we've heard a lot about already, which is the reason why we're all here today. So EAP is the East Asia Pacific region. EAP, as I'll probably refer to during this presentation, is aging rapidly, and partly because the population is aging, and partly because of different exposure to different sets of risk factors, which we'll also talk about now. The leading causes of death have changed. Non-communicable diseases, or NCDs, dominate the disease profile of many countries in this region. They also account for the bulk of the kind of disease burden in most of these countries. During the past 20 years, conditions that experienced the fastest growth in most of these countries were things like heart disease, lung cancer, diabetes, and chronic kidney disease. China, in particular, stands out because of the way it advanced very quickly from the profile of a more typical developing country with a lot of infectious diseases to a health profile that's dominated by NCDs. So we often talk about disability-adjusted life years in the health sector, and it's basically a measure of combining morbidity and mortality in one indicator. But if you look at the 20 leading causes of disability-adjusted life years in China, there's only one infectious disease left amongst them, and that's lower respiratory infections. And this is just to give you a picture of how quickly things have changed in this region. Living longer does not always mean living healthier. As the proportion of people surviving into older and older ages increases, the prevalence of disability and handicap also increases. And if you look at the sort of picture of disability in the AP region, these data are actually from the Global Burden of Disease analysis carried out by the Institute of Health Metrics. Musculoskeletal disorders, which include lower back pain and neck pain, and mental and behavioral conditions account for the bulk of disability in the East Asia Pacific region. And they've become more important over time. And this is across all ages. John already presented many of these this morning. This is the same analysis from a set of comparable household surveys for China, Indonesia, Japan, and Korea. And we know that disability is measured in terms of ADLs, increases with age, but it's also characterized by inequalities. poorer people, less educated older people are less likely to be able to perform these ADLs and therefore have more disability. We just saw that mental and behavioral sort of health conditions account for the bulk of disability in the AP region. And depression, again, we saw these results this morning, but again, characterized by inequalities. So poorer elderly, less educated elderly, more likely to be vulnerable to depression. And just to give you some idea of what that means, particularly in poor countries, mental health is not something that health systems are able to deal with very well. And like this mental health unit in a provincial hospital in the Solomon Islands, where old people get taken to for want of better alternatives for care. Over time, risk factors have changed, and these changes in risk factors underlie the pattern of sort of non-communicable diseases that we just saw a few seconds ago. Dietary risks were the leading risk factors in Southeast Asian countries, and in the Pacific Islands, it's high BMI, body mass index, that dominates. Smoking ranks second or third in most countries. And in middle and upper income East Asia Pacific countries, risk factors for non-communicable diseases dominate. And if you look at exposure to these risk factors, again, there are variations within the elderly. So body mass index increases with income, as you would expect. And with hypertension, we saw earlier this morning that there are large inequalities, with poorer people more likely to be more likely to have high blood pressure than richer elderly. So we know that the East Asia and Pacific population is living longer, but are they living healthier lives? Yes, there's high incidence of NCDs, higher disabilities, but what do we know about whether or not these longer years of life are lived more healthfully? There are different ways of looking at it. There is a group that has a sort of morbidity expansion hypothesis, which is that as fatality rates fall, that morbidity increases, that people are more likely to have disabilities, chronic illness, and so on, so there's an expansion of morbidity. Or there is a morbidity compression hypothesis, which is that if the incidence of the more incapacitating illnesses can be pushed into later ages, then morbidity will be compressed into a shorter period of life. So this gentleman in the picture here would be the poster child for the morbidity compression people. But to explore these hypotheses further and to think about how population health evolves, people have tended to look at life expectancy and healthy life expectancy, or HALE, which is essentially a class of measures that tries to combine morbidity and mortality. So if you look at life expectancy, LE, and healthy life expectancy, HALE, these have both increased during the last 20 years, so both globally and in the East Asia Pacific region. And if you look within the East Asia Pacific region, you find that the biggest improvements in both life expectancy and HALE were in low-income countries, and the slowest improvements in upper middle-income countries. So what does the analysis of life expectancy and HALE tell us about whether people are living longer, healthier lives? The people who did the global burden of disease analysis also did some regression analysis of life expectancy with healthy life expectancy, and found that for each year of life expectancy increase, there was a 10-month increase in healthy life expectancy. So essentially, that's sort of pointing in the direction of morbidity expansion. So every year life increases or life expectancy increases, healthy life expectancy increases by less than a year. But there is other analysis of similar data, but not necessarily regression analysis, other types of analysis, which show that the evidence is mixed. It's expansion in some cases, compression in other. In the OECD, where there is a longer literature with looking at morbidity expansion or compression, there's, again, mixed trends. In the 70s and 80s, there was a lot of expansion of morbidity, but the recent evidence definitely points towards compression. So that there's improving health in the older populations in high-income, mostly Western countries. Whether it's compression or expansion, the fact is that life expectancy and healthy life expectancy are increasing. And for the East Asia Pacific, this has three important implications. Firstly, people are living longer, some of it healthily, but people are living longer and there's an increase in disability, non-communicable disease and so on. This will lead to a shift in the demand for healthcare, greater demand for healthcare amongst the elderly. Secondly, the increase in frail, dependent elderly will lead to an increase in the demand for long-term care. And thirdly, a positive outcome of all of this is that this opens up new labor market opportunities. So with a healthy life expectancy of, say, 14 years at the age of 60, there is still major underutilized healthy years of work capacity in the population. So what does this mean for healthcare demand and expenditures? We know that health expenditures rise with age, both total public expenditures, as in the case of the European Union, which is shown here on the left-hand side, or if you look at per capita expenditures, as in Japan, on the right-hand side. But is it aging itself that drives up health expenditures, or is it time to death that matters the most? To date, there's been a range of evidence showing that aging has had a weak effect on expenditures per capita. I mean, it's a positive impact on expenditures per capita, but it's not a hugely positive effect. So to the point that this idea that aging has a significant impact on health expenditures has been termed a red herring. Instead, people argue that what matters more is proximity to death. And this is consistent with the evidence, which shows that as people age, expenditures increase in a disproportionate way in the last year or two of life. So the argument is that when increases in life expectancy are accompanied by an equivalent number of years gained in the number of years of life spent in good health, then healthcare spending is driven primarily by proximity to death. Aging itself does not drive up spending. When the OECD did some analysis to decompose growth in public spending between 1995 and 2005, they found that aging explained a relatively small share of the increase in health spending. Much of the increase in health spending in the OECD from 1995 to 2009 was driven by other factors such as technological change and shift in demand, preferences, and so on. So what do we know about the future of health spending? There aren't very many good sort of health expenditure projections available. So here we present what there is. These are projections carried out by the OECD, which included the BRICS, Brazil, Russia, India, Indonesia, China, South Africa. Their projections distinguish between the demographic and income effects on expenditure growth and have two scenarios regarding the evolution of other non-demographic, non-income drivers. And they have two scenarios. So the cost pressure scenario, where no policy action is taken to address pressures on expenditures. Another one, a cost containment scenario. Sorry, a cost pressure scenario where no policy action is taken, and cost containment scenario where policy action is taken. And the findings show that the demographic effect, the pure aging effect, accounts for only a small increase in total spending. So if you look on the chart, the purple and blue bars are the total increases in spending. The red bars are aging, the aging effects, and the aging effects are relatively small. In this region, if you look at country-specific health expenditure projections, we have projections for Malaysia, where an actuarial cost projection model projected expenditures as a function of change in population size and demographic structure, the underlying changes in utilization and productivity changes. The projection model found that under current trends and with no structural changes to the system, Malaysian public expenditures will increase from 3.7% of GDP in 2011 to 4.4% of GDP in 2030, and less than a third of that will be due to population aging itself. And the major factors that will affect the future costs of aging in Malaysia, future costs of healthcare in Malaysia, are changes in private sector medical prices and changes in productivity in the public sector. I want to present to you a little bit about the health financing, the health system landscape in the East Asia Pacific region. Generally, total health spending, both as a share of GDP and public health spending as a share of GDP, is fairly high in the East Asia Pacific region compared to other regions of the world. But some of this is driven by the pattern seen in Pacific Island countries. Within the region, there's quite a lot of variation in the public versus out-of-pocket share of spending. There are some countries where out-of-pocket still accounts for a very high share of spending. So this rapid aging, this increase in the burden of non-communicable diseases and so on, is happening in a context where many countries are have made strong policy commitments to achieve universal coverage. Many countries in this region, Malaysia, Fiji, Thailand, and of course Hong Kong and Taiwan, have already achieved universal health coverage. Other countries, Indonesia, Vietnam, Philippines, have set these policy commitments to achieve universal coverage by 2020, 2030, and so on. And this push for UHC and the previously sort of unmet demand for healthcare is likely to drive up health expenditures. But this would be because utilization rates will go up across all age groups. It's not specifically driven by aging itself. In fact, the important drivers of spending will be medical price inflation, productivity changes, technological changes, and so on. Just very quickly on long-term care, what we have here is a little bit that's coming out of the sort of reviews that we've been doing of long-term care in the region. With long-term care expenditures, again, the only projections we have or expenditure estimates we have are from the same OECD study that projected health expenditures. And what they show, including for some of the non-OECD countries, such as China, India, Brazil, is that pure demographics play a minor role in the cost increases in the OECD. They're slightly more significant for BRICS. But again, these are the red bars, the demographic effects. They're not as large as some of the sort of total increases. But the other factors driving total increases in spending. An overview of long-term care systems in East Asia, I think we've already heard quite a bit this morning. But essentially, there's population coverage for long-term care only in Korea and Japan. With regard to service coverage, there's quite a lot of debate about whether it should be institutional, home, or community-based. On the financing side of things, there's social long-term care insurance in South Korea and Japan, private insurance in Singapore, and a lot of discussion in countries about how best to finance long-term care. What are some preliminary policy lessons that we can learn already from long-term care systems in Japan and South Korea? It's important to design and implement these systems early, before aging becomes a serious issue. It's important to separate out long-term care from healthcare. It's a good idea to avoid cash reimbursements and to provide in-kind services. Again, this goes back to providing care within the community or care where the elderly are and not necessarily at an institution. Co-payment setting can be used as an instrument to encourage the right kinds of provision, right kinds of services. So to encourage community-based over institution-based and to avoid over or underutilization of services. And finally, it's important to build up the cadre of people who will provide these services to secure the provider's number and quality with national standards. And this is basically sort of initial results of our analysis of long-term care in the region. And that's it for the overview.
I think we've got about 10 minutes for some questions before we move on to Winnie's presentation.
last year. So there is no increase in these 10 years, but just the year before that. So it's true that Asia doesn't give additional expansion. But from the point of view of the society, is very different because if you imagine two societies, one with 30% of people 2 years before they die, versus a society whereas you have only 5% of the people at 2 years before that. So the first society is an aging society and has a much higher cost than the younger society. So there is a discussion of it seems to be a bit balancing argument that aging doesn't create an increase in balance.
I think, put simply, that aging doesn't drive up expenditure. It doesn't sound intuitive, right? That when you have this hugely sort of aging population, that they would have no impact on expenditures. But so some of the argument is really rooted in the fact that all the disease, the expenditures are pushed to the last 2 or 3 years of life. But the OECD's analysis from the retrospective analysis, the 1995 to 2005 or whatever, showed quite clearly that during that 20-year period, that even though there was rapid aging going on in many of these countries within the OECD, that the bulk of the spending increases did not come from specifically from the structure of the demographic structure shifting. It was more the technological change and other factors that we would normally expect expenditures to be driven by, shifts in preferences, demand, and so on.
That is healthcare, though, right?
Healthcare, yeah.
It's really how you define increase in expenditure.
As a share of GDP.
I define it as a ratio of deaths to total population, and all the population has more deaths.
As in public debt?
Deaths. No, deaths. Dying.
Oh, deaths.
I'm Italian, I have English. If you have more deaths and more people dying, as a percentage of your population, your health expenditure is higher. I don't. It's the way you define health expenditure. We can discuss.
Yeah.
Can I speak to that a second?
Sure.
The finding is everyone always figures that more older people you're going to have higher healthcare expenditures. However, unfortunately, when they started looking at the countries of the world and correlating the number of old people they had with their health expenditures, it doesn't work at all. It doesn't predict in cross-sectional analysis. Moreover, in longitudinal analysis, to give you a dramatic example, I'll make the numbers up, but they're more or less correct. In Japan, in the 80s and the 90s, aging was the most rapidly, up until then, ever seen in the history of the world. Aging was going very rapidly. In the United States, aging was flat. It was dead at 12% of the population. In the United States, healthcare costs went up 5% a year. In Japan, they went up 0.5% a year, 1/10 of the rate. So in the real world, aging just doesn't
come up.
Your analysis sounds perfectly sound, but in the real world, aging, the proportion of old people and health expenditures, either cross-sectionally or longitudinally, doesn't matter very much. Other factors do.
Right. So yeah, that's what comes out in the data. Sorry, go.
That's a point of how they do the studies, is that stakeholders or factors constants are isolated the fact of the aging. And I think going to what people needs to be measured more is what percentage of the population is within 2 to 3 years to death. Because just because the percentage of the population over 60 grows dramatically doesn't mean that the percentage of people that are within 2 years of death grows as dramatically.
claim rates by age and by sex, and they would go up by age and sex. Now, if that matrix of claim costs stays the same, and the population ages, and you multiply the rate of each age by the number of people in each age group, it has to go up, right? Cost has to go up for aging. The only way that you can argue against it is to say that that curve changes and that you're pushing that curve out, and so that my rate of 65
Right. They're pushing the,
as we go out, right? If you have a constant curve and you change the weighting on it, you make the people older, and the older ages have higher claim costs, it has to go up.
No, but if life expectancy is getting higher than
Right.
the 60-year-olds used to be, have
Right.
a high premium, now they're low because they're not going to die for another. So it shifts across. I mean, just a simple thought experiment is if you only paid health care in the last 2 years of life and life expectancy increased, then your average spending per year of life is actually going to go down. Yeah, because it's spreading over more years of your life. And so there's no reason why it should increase with aging.
There's a comment here. Yes.
Actually, following up on that point, if you go back to page 17 here, the curve actually flattens out for the healthcare per capita by age.
Depends what country you're looking at.
It's page
this
17.
isn't work. I know, this isn't working for me anymore.
Like in some countries, it flattens out. People just stop going.
Am I pointing in the wrong direction?
They can't travel to hospitals by themselves, like in Thailand and Indonesia. You see that unlike the Western countries, it goes up to about 70 and then it goes down.
17.
There's a little bit of research that we've done on it. The reason that it seems to go down is that at age 70, people can't travel by themselves to a health facility. People in their family can't afford to take time off from work to go with them, so they stop going for care. So again, there's so many factors here that can be mixed together. There's also global budgets, there's also managed care, there's all kinds of other factors that come into account that you follow something longitudinally. But the only way, if you just try to isolate out the cost of the aging, unless you're going to argue that the curve shifts from year to year such that those high costs get pushed out, then it's possible to argue that the costs don't go up with age.
That's the argument.
That's exactly I just found out only today that apparently Hong Kong has recently done some health expenditure projections. Can you talk on to that?
Well, I mean, in Hong Kong, everybody travels quite easily to hospitals, and we pay for all of them. Hong Kong is now, by the way, the highest life expectancy at birth in the whole world for both men and women. And yes, it is flat as far as demographics go. So aging doesn't drive that. It's just time from death, essentially. It's the last couple of years. But I think the point really is not healthcare. I think that question is pretty much settled. I think the question that is not settled, which I have questions about, is that long-term care stuff that you talk about, that you say that demographics don't really matter. Now, that same argument cannot go for long-term care, because long-term care, by definition, is so long as you live, and the longer you live, the more you generate, because these nursing home costs and so on and so forth, you can't say, oh, you only use that in the last couple of years of life. So my question is, well, how come the OECD average shows that demographics don't matter here either, as opposed to healthcare? Now, healthcare I accept, because actually if you look at most of the empirical literature in the world, including Hong Kong, that is the case. But this is not what we find in Hong Kong, that actually aging is the main driver of long-term care costs. This I don't quite understand, because I don't understand the argument here. You can't
I wonder if it's about the starting point though, because for the OECD they already had very expensive systems in place. So when they started predicting it in 2010 or so, there was.
No, but I mean, if people live longer, I mean, if you've added, another 5-10 years of life expectancy, that's an extra 5-10 years of long-term care costs. These are not acute things that you have a COPD flare-up, or you have pneumonia, you have heart disease. Yes.
In terms of long-care utilization, the main predictor is not really your age. The main predictor is your disability.
ADL and IODL,
disability,
yes.
Right.
Yes,
so
which
it's
is
quite
highly age-dependent. Unless you really believe James Freeze's compression morbidity, that adding another couple of years means that it's completely healthy, which is not true.
No. You won't expect them at the end. You expect them at the middle. So if before a 65-year-old would have serious disabilities with increase in healthy living and so on and so forth, the disability is happening actually late in life. In the US, for example, the average stay in assisted living facility is 18 months. So before that, people managed somehow to stay at home, and I'm sure they're utilizing some long-term care.
You think that people really are that healthy, or you think that it's basically denial of service until the last 18 months?
It's not really denial of service in the U.S. because Medicare pays for that, so it's not. There is a cap, there is a cap, of course.
I think what you said is the other idea, because if you compare this contribution of aging factors to total increase in spending, this is long-term care, and previous one is healthcare. You can easily see the contribution of the demographic effect in long-term care is greater relatively compared to the healthcare.
Well, sure.
Yeah. So what is the message here is that the demographic effect is not all. I mean, there are other factors as well, but may not be as big as.
Well, I think that's the main point. I don't think she's making a statement and saying that aging doesn't matter. She's saying that aging's contribution to health expenditure growth is not as big as the usual perception if you compare to other cost drivers as well. I think that's all she's saying. Am I paraphrasing incorrectly?
You are.
Last couple of comments, we really have to move on
this. Of course, there are technological factors. There are new innovations, like you can try and cure cancer, so that adds to the cost of treatment. But being from a reinsurance company, being from the insurance background, I can say that, of course, with aging, the cost of treatment increases, the health expenditure increases. That's precisely the reason insurers do not like to insure people who are above 75 or a certain age category, because the health expenditure tends to increase with more of aging. That's what the data says from claims.
So I think part of the answer to this question is what you're analyzing. So if you analyze total health expenditure, GDP is going to have a huge impact on that, or total consumption. If you look at health expenditure as a share of GDP, which I think is a more natural thing to look at, then aging is going to have a much bigger effect. And the other thing is the crude death rate is rising in Hong Kong. And that means that the percentage of people who are in the last 2 years of their life is rising in Hong Kong. And that's because of aging. A higher percentage of Hong Kong's population is in the last 2 years of its life.
So any projections with respect to that age?
Yes.
It's,
as a percentage of GDP, Hong Kong hasn't spent, even a fraction of a percent more for the last 10 years. It's flat at 5.